Welcome back to our symposium, Building a Robust and Proactive Public Health System in Connecticut. A symposium hosted by the Expand Services to Save Lives Coalition, a coalition that's fighting to restore and expand our public sector safety net so all people, regardless of race, gender, zip code, immigration status, whether you have insurance, whether you're incarcerated, what you're capable of, all people have access to the life-saving public health care services that they deserve. I just want to remind folks that if you've just joined us, that you have the option to listen in English, Spanish, or follow along in ASL. Just click the World button at the bottom of your screen. I am so thrilled to introduce our next speakers, two very special guests who will provide opening remarks before our next panel. Representing the towns of East Hartford, East Windsor, Ellington, South Windsor, Senator Saud Anwar is one of our finest champions in the legislature. He's chair of the Public Health Committee, and we know him. He's bravely fighting to ensure all of our residents have the resources that they need to live healthy and thriving lives. And of course, this is based on his years of experience as a medical doctor. He's a fierce fighter for justice, a great friend to 1199 and so many of our organizations. And I will let Senator Anwar do the honors of introducing Dr. Emily Wang from the Transitions Clinic Network and the SEICHE Center at Yale.
Thank you so much, Rebecca, for your kind introduction. Good afternoon, everyone. It's such an honor for me to be part of this conversation and with all the people who are part of the panels, but especially with Dr. Wang. I wanted to first just mention that, we are living in very challenging times with respect to healthcare and also the health and well-being of our citizens in our state. We knew even before the pandemic that things were not good. The pandemic amplified the challenges. We recognized it clearly. We tried to look at the best way to intervene, but by that time, too much had happened and the healthcare workforce were impacted. The systems, which are weak, progressed and worsened even further. And now the most vulnerable in our state are actually even worse than what they were at before. And then there's so much that needs to be done. There's so much that in investment and efforts and coordination that is going to be needed for us to do this. And having these conversations is so critical. I am so honored to be here with Dr. Emily Wang. She is a professor in Yale School of Medicine, and also she is the director for the SEICHE Center for Health and Justice, collaborating with the Yale School of Medicine and Yale Law School, and also does lead the center's research. She has, and the center has been a recipient of the NIH grants and funding to specifically look at the incarceration influences chronic health issues associated with it. She is one of the founders and directors for the Transitions Clinic Network of consortium of 40 community health centers nationwide. And she is served as on the National Academy of Sciences, Institute of Medicine's Health and Incarceration Workshop. She's been published at every important journal on these issues. She is somebody who is making a difference at so many levels in media and other places. And I wanted to take this opportunity to welcome Dr. Wang. And since I'm here welcoming you, I just also wanted to put this on your mind that when you get the Nobel Peace Prize, invite me too.
I really appreciate the honor and opportunity to know you, Dr. Anwar, Senator Anwar, and the opportunity to be here at the symposium. There's nothing more important, I think, and in these times, the vulnerability of my patients and the communities that we all care about are at stake.
So, Dr. Wang, tell us about the research work that you're doing around the conversation that we are looking at today.
Sure. I might, if you don't mind, I'm going to take a pause just to say, we're both doctors, and I thought I would start with just a patient that I've seen Just to kind of put it into stark reality, I've been taking care of now, at this point in my career, thousands of individuals that have come home from prisons and jails. And, almost 15 years ago, I remember kind of seeing patient after patient in our emergency departments that had come home after incarceration, sometimes sentences of decades, sometimes just days, where they would come in with basic things like, hey, I was on dialysis when I was incarcerated, and now I do not know where to get dialyzed, and would have kind of grave levels of potassium in their bodies and need emergency care. Or alternatively, because there's a constitutional guarantee to healthcare behind bars, but none when they come home into the community, they had been diagnosed with high blood pressure, diagnosed with diabetes when they're incarcerated, but never had drawn up insulin for themselves, came home, didn't have an ID, didn't have their medications, didn't know where to get primary care, and came into our emergency department, which is, really trying to take care of emergencies, just needing to figure out how to take care of these basic health needs. And it's this impetus of patients who, for me, have been kind of the focus of our career, have led to a research inquiry of really trying to understand how best we improve their healthcare. They're coming from a healthcare system behind bars. There's a whole healthcare community behind bars, to one that in the community that is really siloed, really never communicates. And so what we did was start investigating what are the health outcomes of people when they come home from prisons. And it probably is no surprise to you, Dr. Anwar, that not surprisingly, when in large studies over and over in multiple different states, we have found that immediately upon release, in the days, weeks, and even months following release, there's a high rate of dying, high rates of hospitalizations, often from preventable conditions. And these include overdose, as we're seeing right now, but also heart disease, cancer, conditions that are preventable, uncontrolled diabetes, conditions that if you were engaged in primary care, you could prevent a hospitalization or even a death. And so this began for us a process of trying to figure out how best to what we felt like at that time, how best to fix this issue, this transition of care. And almost 15 years ago, working closely with civil rights leaders, community members that had been incarcerated themselves, designed a program that was really trying to bridge the healthcare of people that move in and out of our prisons and jails. And so created, as you alluded to, the first transitions clinic program, and the core of which is a community health worker, a person that they themselves had been incarcerated, had been successful coming home to the community. And that person then would be situated within primary care to work with folks just like myself, a primary care doctor, to really bridge this vulnerable population from coming from a prison or jail back into the community. And so we have, over the last decade or so, have studied how investments in community health workers, investments in primary care really do improve the health of those that move in and out of prisons and jails. And it kind of seems like a no duh, like, of course, primary care, of course that's how we should be thinking about it. But it's something that we don't talk about a lot, that criminal justice reform is on one side, the healthcare system is here. And really, there's a whole healthcare system behind bars, as you well know, and it doesn't communicate with our community healthcare system. And in doing so, creates vulnerabilities and inefficiencies in the system. And so we have found that if you hire community health workers, it in fact, it creates efficiencies in the system. So fewer patients come into the emergency department, fewer patients need hospitalizations that are preventable. And also, and these data come from Connecticut themselves, reduce the cost to our criminal justice system. And so it's this that's been the focus of much of our inquiries at the SEICHE Center.
Wow. So I'll share a couple of things. So this session, I proposed a bill to have the community health workers be compensated by Medicaid, their services. And peer navigators also, we should probably have them be covered by Medicaid services, because the cost of that investment, we save far more money, and especially the vulnerable populations. And we had a bill last year for the first time to actually look at how we can improve the Department of Corrections health. But what has happened is before a person goes into the correction system, they are not in the best health to begin with and have challenges. And then when they're on the inside, they have another group of challenges and lack of appropriate level of management. And then subsequently, when they're out, that transition at all the levels is pretty much setting them up for failure from a health and well-being perspective. You've talked and written about the breaks in care and the breaks in health as well, as I would put it as well, because the fact that we have created a system where there's a break in somebody being healthy, and then we have created a break in the system where they cannot even get access. So can you speak to some of that?
Yeah, and I think, so many of you here on this webinar already are experts working within the healthcare systems. We know it too well, but for those of you who aren't, I will kind of break it down, which is that when individuals are incarcerated, they move into a jail and then move into a prison, and there's a whole healthcare system behind bars. When I train new medical students or residents, really describe it as this is a different sort of healthcare system. It is constitutionally guaranteed. There's good-minded physicians that are practicing inside, nurses, et cetera, but access to healthcare is entirely different. How they engage in healthcare is different. Patients, when they, for instance, are newly diagnosed with their blood pressure medication with insulin, and depending again on the prison or jail you're in, don't necessarily learn how to manage that chronic condition while they're on the inside. They have a nurse that is kind of giving them the medications, the nurse that's giving them the insulin. And then when they return home back into the community, there's almost little to no, in most settings, real communication between physician to physician or provider to provider. Here in Connecticut, I will say, and I'll say from the community standpoint, we often don't know when our patients have gone inside. So, there just isn't a lot of communication between these two healthcare systems. And of course, when people cycle in and out of the prison system, in and out of jails, what ends up happening is that there's a lack of communication between the healthcare system writ large. And so for that patient that is, dealing with this high blood pressure, trying to figure out how to get his medications when they come home from the carceral system. And especially if they've never had to use it before, they're diagnosed while they're inside and don't know how to get care when they've come home. There's almost an impossibility of managing that chronic health condition. And so, where we have felt like there's a real kind of gap is filled by having a community health worker. I'm heartened to hear about your bill, and of course I knew about it before, but community health workers serve in so many different ways. And I think first and foremost, you can imagine that of course they bridge, with the team of primary care providers and the system at large, they bridge these siloed health systems. So they're the ones that are helping, trying to get to the medical record if necessary, trying to figure out where the pharmacy has gotten the medications. Here in our Department of Corrections, we have discharge planners, and when we're in communication with them, it's amazing. We at least have a list of medications that comes, and those are critical kind of pieces of information that help bridge the gap, but it's not enough. There aren't enough discharge planners. And so our community health workers are then the ones that are reaching inside to kind of help facilitate getting more information for providers on the outside. So that's one way that they bridge this break in care. The other ways is that I think it's important to think about that healthcare is one component, but there's many other social services that patients like mine need coming home from prison or jail. And this includes accessing our social safety net, trying to figure out how they're going to get housing, food, trying to get a job. And so our community health workers are that glue too. They hold together how the patients then accesses our pretty fragmented social service system. And then the third way that they really kind of break a gap, and I think we often don't talk about this, is that our patients that are moving in and out of kind of the criminal justice system also have to interact with a probation officer, parole officer, and with our patients' permissions, we're often in communication with them, trying to talk about things like opioid use disorder treatment, where a person's actively engaged, where we think that going back inside, if they've been violated, may not be the most judicious decision given their health. And so it's in these ways that the community health worker really holds together systems that often aren't in close communication. I'd say the last piece, now I'm blabbing on and on, but the last piece is that because they've been incarcerated themselves, in almost instantly, it's a place where trust can be slowly built over time, in a system that's really kind of not been very trustworthy. Our health system, as you know, Dr. Anwar, has really created all sorts of barriers for these patients accessing humane, efficient care. And so having a person that has had that shared experience can help start to build trust into the system, help navigate stigmatizing or discriminating experiences within the health system. And so in so doing, really hopefully hold together these breaks a little bit better.
Wow. So, you know, in the people in healthcare workers, they sometimes are not selecting this arena as the area of service. And from what I gather in my conversations with people and my individual patients that I come across who have, it's very rewarding to be able to help somebody not only get better from their health, which has been mismanaged or not managed for a variety of reasons by their own choice in some situations or otherwise, and then get them together so that they can rebuild their lives. Tell me about the emotional impact that you see in your residents and yourself and others by providing the service to the most vulnerable in our state.
Yeah, you know, I appreciate that question. I do think that there is, for primary care providers, there have long been a real kind of tax on the system as a whole. You know, I heard you speaking about nursing here, and what we're being asked to do by being kind of a primary care system is really so much, right? To hold together, to think about how it is that you provide health and well-being in a time when the social safety net system is really fractured. I think the contrast for the residents, the students, and then of course myself as a provider of being able to work in a team. So, you know, here in our transitions clinic program in New Haven, we not only have a community health worker that's been incarcerated that's working on our team, we also work closely with the medical legal partnership. So where we have the ability to attend to people's civil legal needs, as well as a psychologist. And so in so doing, building a program that attends to people's multiple different needs, there is a real satisfaction of knowing that you're not just, you know, prescribing their blood pressure medications, their hydrochlorothiazide, or getting them to dialysis, which is important. But it's also attending to the issues that really make people well and whole. So, you know, how is it that we can get you in a safer place, in a house that you feel safe in? How is it that we get you reunited with your family? And I think that that's the conversation we need to be having in thinking about how you create public safety. You know, is that it can start, it's not the only place, but it certainly can start in a primary care office, but certainly in the community where we're thinking about the various different resources that need to be brought to bear to make our communities more safe.
Right. So in our earlier conversations today and later part of the day today, we are talking about the physical health, the mental health, but also addiction services. So Dr. Wang, what is your prescription for the state to address all these challenges?
Yeah. You know, so I think there's no one single way that what we're going to do is then fix the healthcare system writ large. As you alluded to before, for the most vulnerable patients, and I would contend those with opioid use disorder, those with mental illness, and certainly those that pass through carceral systems, the system in and of itself, as is prior to the pandemic, was one that created almost insurmountable barriers to really get healthy and whole. And so I think it takes a real multi-pronged approach. You know, when I think about the work that we're doing, I think it does require investments in a new sort, you know, of personnel, people that are from the community, that people can trust. Community health workers, I've had so much experience working alongside community health workers, and believe that if you don't attend to the distrust, if you don't attend to the discrimination, the stigma, then we aren't going to get to where we need to get so that people do trust the healthcare system. So that's one piece of it. I would say that the other is that it is important to know that there is, again, among the patients that I take care of, they do pass through another healthcare system behind bars. And so our colleagues behind bars, the discharge planners, the healthcare workers, are also in need of support to be able to make these safe transitions home, such that we're able to keep them home and hopefully have them never go back in. And so to me, it's both thinking about the people, the kind of expertise that needs to be brought into our healthcare system, the investments that need to be brought in into kind of hiring more community health workers, and also really trying to think about how it is that we can bring down the barriers for people coming home from prison. So, one of the things that I think is really important is thinking about kind of just the bare minimum. Many of my patients come home without identification. You don't have identification, then how are you going to get healthcare? You don't have identification, how are you going to get your food stamps? How are you going to get housing? How can you even get a driver's license without identification? They're moving from a place where everyone knew who they were in a carceral system, and now they've come home. And so the barriers that are enacted by our state, by our systems, by our institutions, just need to come down. And that includes our healthcare system. We need to be prioritizing the care for these patients, in particular, given their vulnerabilities, given their high risks of hospitalizations and death. It reminds me, Senator Anwar, something that I think is really interesting. Connecticut's been at the forefront of getting individuals that are incarcerated either on Medicaid, enrolled on Medicaid, or not, terminating it. So when people come home, the vast majority of my patients that qualify for Medicaid have been on it. But large national studies have shown that in spite of the expansion of the Affordable Care Act, where individuals who have criminal justice involvement newly obtained Medicaid, that it didn't change the rates of engagement in opioid use disorder treatment. It did not change the rates of engagement in mental health treatment. And our own hypotheses are that there's just too many barriers, right? There's not enough providers that take care of these patients, that accept Medicaid, that patients don't trust that they're going to get good care, that we need, in other words, community health workers, more active ways of engaging people into the system. And so these are a couple of different ways that I think the state can really build and foster a better system of care to really attend to our patients' needs.
This is very fascinating. I had somebody who was, there's a report that is anticipated. And in my informal conversations with the people who are writing this report, they felt that a lot of people who are incarcerated, there's a very high number of individuals whose underlying mental illness was never diagnosed or treated. And because we don't have a robust outpatient and inpatient mental health system, the prisons are becoming the de facto way of managing them, and the people over there are not trained and able to address that. Obviously, in the prison system, I'm not talking about the health part of prison systems. What's your experience about that?
Right. I too have heard both researchers and physicians and patients talking about this. I deeply believe that, especially for those that are underinsured or poor, access to mental health treatment is under-resourced. And so I guess I would just start there. I also think there's something about your comment that I think is really important, is that, in my work, oftentimes people will just focus on they'll say, well, that's great, Emily, you're working with incarcerated individuals, but that doesn't have anything to do with us, right? Like, we see families, we see children. And in fact, to me, the comment that you're making, Dr. Anwar, reminds me that this is about kind of investments in, people over their life course, that if we invest in mental health, if we invest in our communities, if we invest in access to care early on, when kids are kids, and when they can get the resources that they need, that is the most profound kind of investment that we can make in really kind of trying to prevent incarceration, trying to prevent mental illness from spiraling, and hopefully ending up with fewer folks that pass through our carceral system. So many now in Connecticut, it's families are impacted. So it's not just the patients that I care for, but it's also their family members and children. And the research really do show that the health impacts of incarceration extend well beyond those who are incarcerated and affect family members, especially partners of individuals who are incarcerated, and children too. And so attending to the system at large also includes attending to the needs of family members that are left behind and their kids.
And the organization SEIU and 1199NE, they have organized this gathering and conversation. According to the estimate, there's a need of 1,000+ people to be able to provide help. So there's a preventive component, and then there is a management component when the person comes in. So the safety nets that we are supposed to have in our state, because of the healthcare workforce not being there, not interested to be there because of at times the salaries and all of those combination have led to the prisons being filled or the hospitals being filled because of some of these failed policies. Could you speak to that too?
Sure. You know, I have no doubt that 1199 has done due diligence, and if it's 1,000, then it's 1,000. From my end, and thinking about again community health workers, what I would love to see is that for every individual that comes home from Connecticut's prison or jail with a chronic health condition, that there is a community health worker that can attend to their multi-pronged needs. And that, in and of itself, just for those, really requires 40 to 50 community health workers coming home. And so that's just for this specific issue. I would have no doubt that, our healthcare needs are profound. I, like you, practice medicine, and we can see it each and every day on our wards in primary care clinic. I certainly see it in our colleagues within the Department of Corrections who are in our discharge planners that are working hard, trying to provide a transition of care, and this is just critical.
Yeah, I've had the opportunity to meet with some of our colleagues in the prison system. They are working very hard because they can't recruit enough people. And that's part of the challenge that we have is, and we're hoping to have a bill that's going to actually have the salaries be at par with the market outside of the prison system. If you're having somebody work in the prison system for healthcare and you're not even paying them the same that they can get in another place, they're not going to apply for those jobs. Dr. Wang, any final words of more wisdom? I am just, I don't know if you have a fan club, I can actually sign up for it. You're doing some great work. It's amazing what you're doing, and I can't thank you enough for that.
Well, I appreciate kind of the opportunity to be on this panel. There's really nothing else that I could be more excited about than community health workers. It's a career path for so many individuals, colleagues of mine, friends of mine, individuals that have so much to contribute to our healthcare system and contribute kind of to the well-being of our community. So, if there's ways that we can hire more formally incarcerated community health workers, I'm on board.
Good. Thank you so much. Thank you everyone for listening in. And I think, Rebecca, this should be we're 1 minute ahead.
Yes, thank you so much, Senator Anwar, and thank you, Dr. Wang, both so much for joining us today. It's been such an honor. And thank you both so much for your tireless efforts to really build this public health infrastructure based on the principles of solidarity, justice, equality. Thank you so much for that really incredible conversation. So we're going to turn to our second and last panel for the day. I'm really proud to introduce the moderator, Enid Rey. Enid is an attorney and a consultant. She's nationally known for her work in advocacy and positive youth development and civic engagement, and was a local leader in Hartford Public Schools. We are just so honored to have her moderate our final panel. I will pass it over to you, Enid.
Thank you. It is an honor and a pleasure to be here. And I really want to pull on some of the themes and threads that were just talked about by Dr. Wang. Cannot co-sign enough, right? That some of these strategies and what needs to happen, they're low-hanging fruit. They're there ready for the taking. This issue of meeting identifications in my work with young people, that has always been critical when young people have been coming out of care, whether it's foster care or juvenile justice. And then I was also struck by this piece of, there is a compound interest to this issue. And we as a community need to make the right investments so that that compound interest is positive and not negative. There is a ripple effect, right, that our incarcerated community members and their families experience, because when one person in the family is ill and cannot get care, it really affects everyone. So today in this panel, we're going to talk a little bit about children's mental health and the crisis that we've all experienced. And I think we all come to this conversation with some lived experience, right? We know of a family member, we know of a neighbor, we know of a mentee, we know of kids in our schools who have had are challenged by accessing mental health. And we know that their families are challenged. So we have a great panel for you today. And I will just have each of the panelists start by introducing themselves briefly. But we'll start with the question, right? The question is, we've heard about the unmet need and that it's really in many of our most vulnerable communities in Connecticut. So what can the state do? What should the state do to address this crisis? And how do we stabilize and expand the safety net, particularly in the public sector and in public-run organizations? So I'd like to start with Donna Brooks, who's the former director of the Women's Star program at DMHAS, now retired. But I know, Donna, this is a big passion of yours. And if you could just introduce yourself a little bit and from your perspective, right? Because all of us bring a different lens. What do you think can happen? What do you think can be done? There's low-hanging fruit and then there's strategy and long-term. Donna. Get us going.
Well, that's what I was beginning to talk about, that we haven't been engaged in cost savings during this period of austerity. We've engaged in cost shifting, and the cost shifting ends up in the very high price of medical care in the emergency rooms, in lives that have been lost, general hospital admissions, broken family, increased incarceration. And there's certainly a better way to do this, because what we're doing is we're harming families, we're harming individuals. And I think the trauma that a child experiences amidst all this chaos, how are we preparing them for later life? Because they're going to be a parent someday, they're going to be working, as a co-worker of some of us. And if we've not treated the family, all of the individuals involved, I just think that we're missing an opportunity. And Brian had said, if not now, when? And I would like to add to his statement, all we have is now. And with a budget surplus, now is a good time to start. I would certainly like to see the Women's Star program begun again, because not only do women get better in a gender-specific program, but men also get better when they don't have the distraction of women in their program. So I guess with that, I'll pass to someone else and I'll weigh in a little bit later. Thank you so
I
much.
appreciate that, Donna, because I think it's there. The urgent call is now, right? Because we're often waiting for the resources and we have an opportune moment. So Dr. Llovet, from your perspective, how does this play out? What should be done? What should be prioritized And how do we strengthen our public sector safety net?
Well, the most fundamental thing we can do is fill those empty positions that DMHAS has as far as the mental health system. Working in both the outpatient and inpatient units, what I've noticed is this shortage of nursing, mental health mental health associates is really compromising the safety and the well-being of these clients. The attention that each client needs, they can't get because of this shortage. It's harder to prevent people from becoming dysregulated. It makes for a less safe environment. It impedes the treatment. And also this thing about recidivism in hospitals, it delays discharges. And so we have this lack of beds throughout Connecticut. And you were talking about in the outpatient department, how we don't have enough clinicians. We don't have enough clinicians to engage with and pay the attention to and have the consistency that's needed to treat these people. They are mostly the chronic and severely mentally ill people, also people with a great deal of trauma. We're talking about people who are undocumented and coming from countries who have had a horrendous experience there and who now have families and children and are trying to raise these children and deal with this horrific trauma. And they are disenfranchised. They have to find a way around things. And again, case managers, clinicians, therapists need to be consistent. They need to be there when that person calls in crisis. And that's not there. As far as psychiatrists, there's a psychiatrist shortage, everybody knows that. We have to prioritize. The people that we see and are like we're going to see more often are those that are having like disruptive behaviors and are the most, creating the most problems for other people. And those that are sort of quietly suffering don't get the attention. They don't get what they need. So if we could move up on this availability, of hiring enough people, enough clinicians. There's no substitute for a caring, qualified individual in this profession. If we could move up on hiring these people, I think that would be one of the most fundamental thing we can do to help rectify these things. Additionally, there's other programs that really access to rehabilitation, access to substance abuse rehabilitation programs. It is so difficult to get people into these programs, especially when they're ready, which we know, how important that is to be able to, have that, make that phone call when somebody says, yeah, I've had enough. And that actually can save lives, especially with the fentanyl crisis. Also helps people and families and so forth. And we also have to kind of admit that there are people that they don't get well enough to live independently. I mean, used to kind of stop pretending that doesn't exist. There is a great need for residential programs to help people like that. And also for residential programs and expanding housing programs for people coming out of prisons, for people, young adults who, see themselves now out of the DCF system. And those kinds of programs have really helped with the recidivism and with the issue of homelessness, with the issue of incarcerations. Also, I think greater use of ACT team services. Dr. Wang was talking a lot about, connecting people to services, and that's what ACT teams do for the mentally ill. Mm-hmm. It's just so helpful for people whose illness has sort of robbed them of their initiative and their resources and their ability to organize, to have somebody help them with this, to have somebody prompt them, sometimes even transport them. We are having a lot of what our nurses are doing right now is trying very hard to set up medical appointments for people who then don't make it there.
Yep. So you've proposed and you've highlighted, I think, kind of the whole network of pieces that need to be in place to help folks in their well-being, right? And it's very easy to see how this ripples out and affects families and neighborhoods and communities.
Yes.
It strikes me too that you touched on the issue of what can be force multipliers, right? You either pay now or pay later. There are things we can do now that avoid those higher costs later, and that really help to, if we were taking an economic development argument, we'll get there, Emily, but that we could see that this can also help employment in communities, because employing folks from communities to be able to help in some of these aspects could be a viable strategy. So thank you. I want to move to Gretchen now and talk a little bit, Gretchen, about what you see, because you're in a space where we're talking about physical health for women, and a woman's health often determines the health of the entire family. So from your perspective, what do you see as some of the takeaways and things that can be done?
Thank you all for having me. My name is Gretchen Raffa, she, her, from Planned Parenthood. And I think as I was listening to the last two speakers, we represent obviously a nonprofit, the largest provider of family planning and sexual and reproductive health care to over 61,000 patients every year in Connecticut at 14 health centers. We believe healthcare is a fundamental human right? I think everyone on this call probably believes that, and it should be guaranteed to every person in our state. And I think that's where our state is failing. We know that at Planned Parenthood, almost half of our patients that we see have Medicaid as their insurance coverage. 54% of the patients we saw last year identify as people of color, and as an integral part of the public healthcare system in Connecticut, it's critical for Planned Parenthood and other, community healthcare and safety net providers to be well funded, but also working in partnership and ensuring that the public sector is well funded as well, so that we can work in partnership. We see patients every day at Planned Parenthood where they have unmet needs, in all sectors. And we also know that the patients we see every day are the same folks that have, historically faced significant barriers to accessing healthcare and financial opportunity because of this country and our state's legacy of systemic racism and discrimination. So, we believe investments in safety net providers is smart. It's preventative care, and that public investment saves the state long term and also helps people, avoid unintended pregnancy, helps, thousands of people every year prevent, cervical cancers, breast cancers, transmission and treatment of sexually transmitted infection. This is really important when we think about not only people's ability to control their reproductive freedom and their reproductive lives, but also connected to their economic security as well. And I think, one of the things that we are always looking at is what are the barriers that patients are facing, what Planned Parenthood patients are facing. And the reality is, for some people that come into Planned Parenthood in Connecticut to get the care they need, they are, shut out of the private and public health insurance systems. That is why Planned Parenthood's fighting alongside advocates calling for Husky for immigrants, because all people deserve access to healthcare, and income eligible immigrants in our state deserve access to that. The state has money. We can invest in this. And the longer this, continues, where immigrants are denied healthcare coverage because of their immigration status, reproductive injustice continues, right? And I think some of the other things that we think about too at Planned Parenthood is looking at some of the public sector and where women are not getting their reproductive health care needs met. And that includes in our corrections systems. It is disgraceful and absolutely unacceptable that women in Connecticut have been forced, women who are incarcerated in Connecticut have been forced to give birth in their jail cells because they couldn't get the health care they needed. That should be unacceptable anywhere, but especially in a state like ours where we do have the resources to ensure that, all people have the healthcare they need to make decisions about their reproductive lives. We're seeing the state now facing a rural maternal health crisis where in rural areas in the state, labor and delivery units are closing. And that means people have to actually travel to have their babies. And that is, again, really, when we talk about a larger maternal health crisis in our state, that is something that we need to be looking at too, as hospitals are closing part of their services.
Thank you, Gretchen. And I think that, you lifted up a really important point that, the health of everyone in the community then determines the health of all of us, right? When one subset of the population is not well, whether that be new arrivals or folks who are, newly released, it really affects the health and well-being of all of us. I want to go to Mia and ask her from her lens, right? Because you are on the front lines with children and families. And how does this play out? This question about what needs to happen, what can be done? Because, that old proverb, right? Don't ask, what is it? History will tell how we're doing by the health of our children, the health and well-being of our children. So what do you see from your lens?
So, hi, I'm Mia Acumulada Bruler. I'm a school counselor at Wilbercross High School in New Haven, and I'm also want to give thanks for having this opportunity with 1199 as someone from 933. Because much like the nurses and the healthcare workers, teachers and educators are really being we're maxed out, we're taxed. As a school counselor, I see children with significant trauma, and it goes beyond just what we normally have thought of, which is, sexual, domestic, physical abuse, to include beyond the pandemic and what that's done. We're seeing a rising number of unaccompanied minors coming from other countries, and who, like was mentioned before, basically trying to escape persecution from pandillas or from, war-torn countries or economic crisis. And they don't have the same protections. We know that. That said, also, our population, as has been said, is predominantly without insurance. And we rely heavily on the community agencies. Sadly, we're at this point of playing whack-a-mole because we're all reactionary and we haven't been doing preventative services. I really feel incredibly strongly that this message of needing to start at the elementary school level with preventative care and mental health has got to start as in 12 years ago. But one of the most heartbreaking things for me is seeing that even in light of Sandy Hook, there has been very minimal response in terms of treating mental illness. And we know that untreated mental illness costs us a lot more emotionally and financially in the long run. So what we're seeing is a growing number of kids in need, a lot more fights, a lot more reactionary, dysregulated behaviors, which are also causing a lot of people to also leave teaching and leave mental health, because we can't do it with, two hands. We need a huge workforce going on, and that's going to cost money. People need to be paid fairly. And unfortunately, community agency workers and public servants do not get paid very handsomely. And we're tired. But I do love my kids, and I'll go to bat for them 100% of the way wherever I can. But you always miss somebody. It's just too many on my caseload. I have, we're asked to have like 250 on our caseload. It's a lot.
So, there's this theme, right, that of the fatigue for both the families seeking care and those giving care, right? In the readings, I was really struck by the human stories of folks who go to work every day trying to do more, but it's just not possible, right? Because what more is needed is more bodies, more investment. So Emily, I want to bring you to this question of, we are one of the wealthiest states in the nation, yet one of the most unequal in many factors, right? Not just this issue of healthcare that we're discussing, but we see it in education, we see it in housing accessibility. What are the windows of opportunity, and what does it take, small and large, in terms of reimagining what investments could look like?
Yeah, absolutely. Thanks so much for the question, Enid, and also, of course, gratitude to 1199 for the invitation to be part of this really important conversation. You said it, we're in a moment that can define Connecticut as a compassionate, equitable state that cares for all residents, irrespective of whether or not you live in a suburb or city. I think too often we're stuck in a scarcity mindset, zero-sum thinking, if you will. That we can't fund, all the things, that if childcare gets funded, then healthcare won't be. And I challenge us all to move more into an abundance mindset. One, that says that we can, in fact, strengthen our public sector workforce and keep our promises to public sector workers. We can build affordable housing for everyone in every town. We can provide universal access to high quality early care. We can equitably resource education and employment opportunities. We can expand critical physical health and mental health resources. We can fund wealth creation measures like baby bonds. And we can, in fact, put more money into the creation of a child tax credit, expand an earned income tax credit, and fund a property tax credit. I think there's, just to kind of talk a little bit about the thread that I heard from my fellow panelists was that we know direct cash assistance through tax credits like the earned income tax credit and child tax credit, or automatic stabilizers like SNAP and TANF are the most effective ways to alleviate poverty. We know that supports like affordable housing and good paying jobs, as well as services like the ones everyone is lifting up, are essential. We also know that it's people, who provide these critical services, and the crisis of unmet need is in large part due to the disinvestment in public sector, into the public sector, and the profiteering in the private sector. And so the data, I think, is as plain as can be regarding what we should do. It's just a matter of doing it.
Mm-hmm, mm-hmm. Donna, I want to challenge you to think about this concept, right, that Emily has laid out. If we took a mindset of abundance, what would abundance look like? You have perspective now, right, as a retiree, but certainly I'm sure ideas about what could abundance look like for the people that you work with, for your colleagues, and for the system that you were in.
Okay, I think I'm unmuted now. So
Yes.
I think abundance is a really great way to talk about it because we have an abundance of money right now. I think the development of a robust and proactive system for mental health and addiction services for adults and children, not only will we improve the lives of the people in care, but we will impact hundreds of thousands of family members, friends, other loved ones, acquaintances, neighbors, the children that grow up in the homes. And so we have an opportunity here, I think, to be able to influence the future for generations to come. And the time is now. We can have positive results. Unfortunately, the treatment programs that we've provided in Connecticut have regressed to former staffing levels that we knew were inadequate in the 80s and the 90s. And here we are, 30 and 40 years into the future, and we're still trying to treat more complex, more complicated patients with the same staffing levels, with inadequate resources. Any treatment program that we provide must be securely wrapped with trauma-informed care. I mean, every day we're inundated with violence, not only in the homes like we've been used to, but in our streets, in the schools, at shopping malls. It seems that children can't go to school without being fearful. And I was a child of the 50s. I remember being in the hallway, and I still remember having that fear when we had to squat down and cover our heads like an atomic bomb wasn't going to be able to catch us in the hallway. So I can't imagine the trauma that individuals feel, especially our children when they go to school. So many of our shootings have been school-based. So I think we can do better. Connecticut can do better, certainly, and we must do better in order to really influence the future, not just for ourselves, but for our children and our children's children, generations into the future.
Yeah, thank you, Donna. Gretchen, I'm thinking about the points you brought earlier about, the effect of women's health, right? Just generally, that it may not feel like abundance to you right now, right? Where you sit. It's a hard fight to preserve and maintain what you have. But what would you recommend in thinking of, linking up? You made this point of you're linking up with others. What else can happen there? What do you see as some of the opportunities there that could create that sense of abundance?
Yeah, that's a great question. I was thinking as I was talking to Becky and preparing for this, I was also thinking about like what more could, the nonprofit and the private sector do to partner with the public sector, and just thinking about, people who have been incarcerated, and when they are back, looking for healthcare, like what are we offering to people that need supports? And how can we better link up with the public sector to ensure that we are able to provide services for people that need it? I also think about the partnerships that we've had with the state through DCF, through DSS and DPH, and really just recognizing that there are opportunities for us to be in stronger communication, but also thinking, especially as I think about the moment we are right now in the movement for reproductive health rights and justice, is like thinking beyond like the legal rights too, and really listening to what communities need, and thinking about, for example, we are working and supporting doulas in Connecticut. There's a coalition, the Doulas for Connecticut Coalition, and one of the problems that they addressed is that they they are not reimbursed for the most part for the care, for the advocacy and the care they provide pregnant people. So we are fighting for policy change, but also thinking about how in community and working with doulas to educate not only people that come to Planned Parenthood, but our communities that we serve across Connecticut about the importance of doula care as an intervention to address some of the poor maternal health outcomes, and thinking about, again, really solutions that are driven by the community and what the community is saying we need to address as well.
Yeah, yeah. I really like that piece of community. And Mia, I'm sure that you think about that a lot in your sector, because schools are a fulcrum for community, right? But kids don't live in schools, they live in communities. And how do we build those bridges out? So what are your thoughts on what can happen to create that abundance?
Yeah, I mean, I think it's wonderful, for instance, that we've started having some community-based school health clinics, like we have Fairhaven Health Clinic within our school, but yet we're still really short-staffed. It's one nurse, one social worker, and our kids, we have like a student body of almost 1,700. So the other social workers in our school tend to work with our special ed population. This social worker presumably would be a catch-all for where we can, because our kids go to these. But agencies like Clifford Beers, they're just really taxed. What we really need is more workers, yes, who are highly skilled in trauma work. Oftentimes we get, and I'm so happy that there are so many people still wanting to come into social work and into mental health care, but we sometimes get kind of out the gate interns trying to work with these very complex situations. Wonderful training, but it's not the best of care. Sorry, I'm going to put it out there. And yet they're wonderful. Like, don't get me wrong, I'm grateful for whatever we have, but we need trained workers. We need this to start way sooner at the elementary level. We need, so it's hired, skilled clinicians with bilingual abilities too. We have a lot of needs, and I'm not just saying Spanish, English, it's Pashto, a growing Arabic, Farsi need, even Ukrainian now, Portuguese. So the list is long. And I think that it would be in that abundance mindset. It would be such an incredible thing to think that, here we are, one of the top 10 richest states, capable of pioneering something that's going to work for everybody. I mean, we need to put our teeth into this really deeply and not just talk. And I think that the workers will show up if they feel like they're going to be supported in that work. Because I myself have considered, do I go and leave? Because I am a licensed professional counselor, and I was doing both up until recently because I'm just burning out really quickly. So I had to sort of scale back and say, no, I'm going to stay with the school right now and not work privately right now. And that was a personal choice because I'm one person, right? But and then it's because of money, right? Because I get a pension with my schoolwork. I don't get that if I work independently. So those are some realities that's why I'm saying, like, we want to show up for this work. But if I knew that I could be a part of a group where it would be shared work, many hands make light work, right? So that's how we work as a union now. And that's how I want to work within mental health, is where we can really help each other also sustain the ability to stay in the work. Because when we have each other, it can be as simple as, just creating even those communities of workers. I mean, just doing this with a panel of like-minded people who are all, it's a wonderful, empowering feeling. And we need that every day when we go to work.
Yeah. And you're bringing up this piece of, right, there are human stories on both sides. There's the story of the workers, and then there's the stories of the children and the adults that need this care. Dr. Llovet, I saw you shaking your head at various points in the dialogue with the panelists. And I guess what I would ask you, is it just about this, frame of abundance? Is it just about restoring, or is it really about transforming? Because, I think both you, Don, and those of us who've been in health for a long time agree, it does feel like we've regressed, right? Rather than move forward.
Absolutely. We have regressed. I was just thinking of a few things while people were talking. We had a wonderful group, monolingual, Spanish-speaking DBT group, very trauma-informed. Those women thrived. It was wonderful. Cut, gone. We don't have DBT groups, let alone bilingual DBT groups. The other thing that I was thinking about is when Gretchen was talking about women giving birth in jail cells, that I've heard that story. I've heard that story more than once. And then having their children taken from them. And the trauma that is for life, and the eternal yearning that they go through. We absolutely need to support these people in a very fundamental way. I mean, there's no mental health treatment that can be given if people don't have their basic needs. It's meaningless without that. So helping people from the get, once they're out of prisons, or helping people from the beginning, if they are, from immigration and having to deal with all this trauma, also helps these children who are going to be the future. Abundance, yes. What would I love to see? I would love to see those groups come back. I would love to see people who are bridges between the mental health system and the medical health system. That is absolutely crucial. We just can't get people the medical help that they need. It is so difficult. I would love to see people who specialize in trauma from these countries to be able to help link people to whatever resources there are out there, which it doesn't seem like there's much. I would love for people to have time to do therapy. What they're doing is crisis intervention, and they're doing helping people keep up with their benefits, and keeping up with your benefits, it's a real chore. It's really hard for people. But they're not able to do more of the treatment. So the inpatient units, where we so desperately need more programming, substance use programming, DBT, life skills, early thought about, okay, when you're out of here, what are we going to do? What is it you want? What are your goals? And actually having it be somewhat realistic. I can see it. I can see where if we could fill those gaps, how much of a difference it would make.
Yeah, and to me, what I hear you saying is creating a sense of healthy belonging and connection in a community, right? That's anchored, that is well resourced, that has people you can go to, like, what is your 911 number when things are not going well? As Gretchen said, it could be community helpers and people in the community. It could be people at the school. But if you don't have a core, right, a fulcrum to help folks when they're in need, we all know things just get worse. Emily, from your perspective, how do we create the mobilization around this? And how do we create kind of the language to advocate on all our various levels in a way that I think bridges, as was suggested by the doctor, the public and private systems, and amplifies, right, the equity of this issue?
Yeah. So I think it's really important for us as a state to seek both equitable investments in supports and services like what we're talking about, as well as systems change to advance equity in where the revenue is coming from to fund these investments. I was really happy to hear, Brian Williams talk about at the top of the symposium that our state's budget is a statement of values. And so we need to address the fact that Connecticut's status quo trickle-down approach hasn't worked for the low and middle income multiracial majority in our state. If we don't address these inequities, we're inadvertently telling Connecticut residents that government can work for some of us, but not all of us. And obviously this is bad, but the reality is we're in a position where we can do something about this. And so I think that's a good way to frame it. My organization has proposed over $7 billion in terms of options for new revenue. All of these are things that we can do to fund equitable investments now, as well as fund equitable systems change, which in turn allows us to recover in a way that puts Connecticut on a sustainable track of economic success for everyone.
I appreciate you bringing the economic argument, right? Because I think sometimes we got to hit folks in the pocket. That's the only time they listen. And when we make it relevant to everyone, there's power in that, in really thinking about what the costs are, short-term and long-term. So I'm going to take a last point of privilege here before we go to some question and answers and ask the panelists my favorite question, which is the magic wand question, right? If you had the magic wand and could do one thing, what would it be? Like tomorrow, we're going to do this tomorrow. I'm going to call you, Donna, and say, we're doing this tomorrow, Donna. You're out of retirement. What would it be?
It's an incredible question to answer. I, for one, would like them to reopen the STAR program.
Mm-hmm.
That program was incredibly effective. We had wraparound services. The women got dental care, vocational, educational, medical assistance, psychiatric care, and then the chemical dependence. And so they were better equipped when they left to help their kids, to help family members, to become workers like we want them to be. And then they pay taxes, which helps somebody else farther down the line. I just think we've lost our way. That program started 30 years ago, and we should have been closing in on a 30-year anniversary. And instead, we're focused on it possibly closing. And dependence is out of control. So it's an epidemic. I think we need to treat mental health and substance use and trauma the way we treated COVID. It's an epidemic, and it's out of control.
That's great.
I don't have all the answers, but
thank you, Donna. Let's do this quick because I'm getting the signal. We have maybe like 6 more minutes. Mia, what's your magic wand? We're doing it tomorrow. I'm going to call you.
No more waiting lists, and my kids get immediate services that come straight to the school to meet with them so that they don't have to find them in the community or at home.
That's awesome.
At school, so.
Awesome and clear. Gretchen, what's your magic wand? Tomorrow, we're doing it after we get coffee, of course.
You're asking the wrong person right now, because I want a whole new Supreme Court, a whole new government. But the vision for healthcare for all. I mean, everyone in our state deserves access to healthcare, and the state can do it.
Yeah.
The state can absolutely do it. We have the resources, and paying our healthcare workers a fair and equitable wage.
That's awesome. Awesome. Dr. Jovet, your magic wand for tomorrow, after we both have a good nap and then go back at it.
I don't know. I don't know where to start. I'm going to start with the thing I see the most. So I'm going to say greater ACT team services, just ACT team services. You know, we talked about children and the future, but right now there is this population of chronically mentally ill people who just are not thriving. They're not doing well at all. They're going in and out of the hospital and they're falling between the cracks. So right off the top of my head, I would say ACT team services and residential services.
Yeah.
So we can, you know, they can recuperate, they can recover, even if it's at their pace.
Yeah, appreciate it. Emily, your magic wand tomorrow.
I mean, I want all the things, but I think it's worth lifting up something that is already funded, which in fact are public sector workers. You know, the people might not know this, but the latest budget update from the Office of Policy and Management from last week says that our surplus has increased again by more than $1 billion, and that roughly 20% of this increase is due to a reduction in spending, of which a major portion is a lack of investment in public sector jobs. And you know, there's tons of data broken out on this, but that's something that we can do right now that is already budgeted for.
Yeah. Yeah, that's a great closer. You know, I would invite everyone to think about the small and large ways that we can activate on this issue. This notion that it takes human capital to do this work well, and it takes financial capital to make sure that the investments are there. And, you know, you all saw during COVID, the folks on the front lines were the ones that kept us all going, that took care of our families, that took care of our children, that took care of us when we were ill. And so I think there is something about we haven't learned our lessons or not put into use the lessons we've learned, right, these past 2 years. So I want to thank the panelists for your insightful sharing and coming from your vantage point, right? It takes many of these pieces to come together, but there is a through thread here of together we can improve the well-being for our children and our communities. So thank you. Rebecca?
Great. Thank you so much, Enid. And thank you to every one of our panelists for that really powerful conversation. This has been such a powerful event, a really just a fantastic day, actually. And so we are going to be moving to our closing speakers. We have two final speakers. So in closing, we're going to hear from Rob Burrill, who's the president of District 1199 New England. And then he will pass the mic to Darnell Ford, who is a lead children's services worker in the Department of Children and Families and a Middletown councilman. Rob?
All right, can you hear me okay?
Yes, we can.
Wonderful, thank you. First of all, I want to thank the wonderful group of just incredibly distinguished guests that symposium. I'm so grateful that we are building a community of practitioners and advocates and policy experts, elected officials, and workers who are coming together to we have a public health and mental health social safety net that leaves nobody behind. That is absolutely, I believe it was Gretchen who was talking about, that we can actually achieve that. That is achievable in a state where there's $1 billion surplus of the people's money. We do not have BS where we have young adult service patients getting shut down, losing a third of the young adults in mental health treatment beds in the state, and seeing children have been through trauma that are difficult for many of us to contemplate, being discharged into homeless shelters. That is unnecessary. That does not have to happen. It does not have to happen that at Capital Region Mental Health's substance abuse treatment program, which used to be able to admit people in a week to 10 days, that we now have workers who came through that very program themselves as clients, rebuilt their lives with the support of state services, which allowed people to access valuable, needed, life-serving care, regardless of income. But clients who are coming through those programs today are told by caregivers for 3 months, for some cases. We should not be in a place where we see waiting sometimes 2, 3, 4 days in a hospital emergency department for psychiatric care when we have that is a state operated facility in Middletown, 10 minutes away.
Hey, Rob, I think your audio is a little bit choppy. If you want to, maybe I will stop video for you and see if that works. And if not, Darnell, we'll have you potentially jump right in. Let's give it 1 second. All right, why don't I pass it to you, Darnell, and then we can have Rob close out when he reconnects.
Okay. Wow. Good afternoon, everyone. And I just want to say that this is truly amazing based on what I've heard. I did join a little bit later because I was doing that direct care work that I could tell everybody talked about. It's been clear just based on what I've seen and what I've heard from this panel and from the folks that I see on the call that we understand that we need staff. We know what needs to happen and what's going on with our kids, our adults, and with all the people that need services. And to be honest with you, what Connecticut has achieved so far and how we make that a solidified process to provide those services for everyone around us. Yes, we've been having this conversation for quite some time, but based on what I've heard, I'm really excited because the people on this call, the new people that have joined, and the understanding that we're still fighting this fight, it sounds to me like we're ready to make those investments that are necessary to move this further, not just to have these constant same conversations and struggles of staffing and struggles of not having services or them falling short. So, Connecticut has the money. We can make the investments. It's a matter of political will. So if everyone in this call, has understood it the way I've understood it, then the best way to move forward is to make sure that we join the fight at every capacity that we can. I invite you on the chat to fill out the form that's going to help us fight this fight and continue. When you go back to your facilities or your agencies or your place of business, or even when you're talking with coworkers, expand on everything that you heard today and how intense it is and how necessary it is. It has to go beyond just our simple conversation. I'm excited about it. I hope everyone else is excited about it, because what I'm hearing here today, we are ready to move forward and change the way in which we have these conversations and put forth the necessary fight to make those stakeholders who have the ability to help us make those changes and stand forward with those changes possible. So thank you for letting me speak here today. I'm really excited. And again, have not only joined the fight, but have other folks join the fight with us.
Excellent. Thank you. Thank you so much, Darnell. Thank you again to our incredible panelists and moderators. Again, please fill out the form Avery put in the chat to join our fight, to join the Expand Services to Save Lives Coalition, to fight for a public sector healthcare services that truly support and serve all of the people in our state, no matter where you come from, what you look like, whether you have insurance. Everybody deserves access to the highest possible quality healthcare, and we can build that as a state. So we will continue to push over the next few months. And so we hope that you join us, sign up with the form in the chat, and otherwise just a fantastic conversation. Thanks to all who participated and viewed in the audience, and have a wonderful rest of the day.